Good morning. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute here in Florida. We are in the one true Melbourne, Florida. Not Australia. It is August 26, 2025. Our patient comes from Alabama. And he's here. He's an athletic man, enjoys a active lifestyle, running, exercising, but he's been incapacitated with back pain for 10 years. We did an MRI review with him over Zoom, and in 10 minutes we knew exactly what was wrong and how to fix it. He has basically two problems: pinched nerves at L3-4 and L4-5. The nerves are being pinched. These are nerve roots coming out, being pinched by herniations on both sides at L3-4, on the right side at L4-5. That's affecting his legs. He's got back pain coming from the discs plus the sacroiliac joints. We're going to fix the SI joints later today. Well, welcome to our live stream. We're going to start by doing an injection of some medicine to numb up the skin. Our patient is asleep. He's getting twilight sedation, no general. This surgery you're watching is outpatient spine surgery. This is the future of spine surgery. We do this here today at Duke Spine Institute. We do it every week. We've been doing this surgery for 20 years. This is laser spine surgery, the most advanced surgery in the world for this problem. Shot. I'm going to use the X-ray machine to navigate to the L3-4 and the L4-5 disc. We're going to go right through the side of the spine to a natural opening that's already there. That opening is called the neural foramen. Everyone's got them. He's got them. You've got them. I've got them. We've all got them. All right, you can show us the neural foramen there on that X-ray view there, Jordan. Thank you. That's right. That's the neural foramen. You see the arrow? It's a hole in the side of the spine. Shot. And we're making the needle go in further, right to the disc. Where is the disc, by the way, Jordan? That's right, that's the disc. You guys see that space between the bones?
Yes, we do.
That's the disc. It's what it looks like on a side view X-ray. Now show us where the herniation is. All right, there's the herniation. It's actually bigger than that, but that's it. The needle tip is right there. AP, we're going to use the next view called the AP view to go ahead and make sure the needle is where it's supposed to be. Any questions, feel free to ask. I'll be happy to answer them for you. Shot? It's perfect. You can see the tip of the needle, show them. It's right between the interpedicular line. It's at the back of the disc, exactly where we want to be. This is L3-4 on the right. We're going to go L4-5 on the right as well. I just made the incision. And I'm going to place my second needle at the L4-5 disc. Any questions? Feel free to ask. Shot?
At this moment, no current questions.
All right. Then let's show the audience all the different things that cause back pain. Shot? I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. Welcome back. Our patient's awake now. He's just talking to me and telling me he's going to go do yard work when he gets home. So we lost literally 3 drops of blood the whole surgery. That's it. We're not losing any blood. We did a 1/4-inch incision. We're going to be fixing both sides at L3-4, only the right side at L4-5. I want to see if these discs are really causing his pain. Are you having any pain right now? How bad is that on a scale 1 to 10?
11.
What's the highest? It went to 11. All right. Is that where you get pain? Is that your typical pain area? That was your L3-4, by the way. L3-4, just so you know. That was L3-4. Yeah, I understand. We're not at your SI joints right now. How bad is that on a scale 1 to 10?
8.
What's the highest it goes? Huh? What's the highest it goes? I went to 9.
10 possibly.
Is that where you get your pain typically? All right. That was L4-5, by the way. L4-5. So you get to go to sleep, my friend. I want you to count from 1 to 100 out loud in Alabamian. All right, whatever you guys count in over there. Nice and loud so I can hear it. Okay, folks that are watching. Jordan, show us the tears in the back of these two discs that are causing his back pain. You see the black line in the back of the disc? Those are the tears. L3-4, L4-5. That's where his back pain's coming from. And we just verified that. L3-4 was an 11 out of 10 pain when I tested the disc. L4-5 is a 9 out of 10 pain. Go ahead and show the audience how these disc injuries cause so much back pain, and then we'll take some questions. So type your questions up.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, I got Dr. Berndes to laugh at one of my jokes while you guys were gone. So you can see from our video that these discs become painful for patients when they get inflammation happening in the back of the disc, right where that tear is. So there's a tear in the back of the disc, we can see it, and that tear is where the back pain comes from. Now, we figured that out here at Duke Spine Institute about 20 years ago, and we've been publishing it and educating people on it for the last 20 years. But it doesn't stick with doctors, and unfortunately we can't get to everybody that has back pain. We try through YouTube and our website. But basically, it's that tear in the back of the disc that causes the back pain. Same thing in the neck. If you've got neck pain, it's a tear in the back of the disc in your neck causing your neck pain. We're going to go in and fix that tear, clean out the disc, clean out the tear, and fix the tear, and that's going to take away his pain. Yeah. All right. Plus, we're going to remove the part of the herniation pinching his nerve, going down his leg. So we're going to stop that weakness from getting worse. We're going to reverse its course. He's going to start getting strength back in his legs. All right, any questions?
Yes, we have a few questions. First one's coming from Jason on YouTube.
Hello, Jason. Welcome. So I'll take these questions, and then we're going to go back to our animation of how the Duke Laser Disc Repair fixes that inflammation in the back of the disc.
Question from Jason asking, this was before the discogram, but asking, do you still do discograms while the patient is awake to see where the pain is coming from? If not, why? I always found it an interesting part of your procedures.
Well, Jason, there you go. We do. But just let me clarify your question. You're saying, do we do discograms to find out where the pain is coming from? We don't do the discogram to find out if the pain is coming from the disc. I already know it's coming from the disc. But what I do with the discogram for is to verify that the pain is coming from the disc. So it's a verification step rather than a diagnostic step. Now, some doctors have no clue where pain comes from, and they just stick needles in the disc and do discograms. And they have no idea whether the disc is causing pain or not. We don't use it as a diagnostic test. We use it as a confirmatory test here at Duke Spine. We are confirming that I was right. But here's the other flip side of it. If the discogram is positive and the patient has pain coming from the disc, it does not mean that all of their pain is coming from the disc. It's a very important distinction. All of the pain is not coming from the disc. The majority of the pain is coming from the disc. In his case, he also has pain coming from his sacroiliac joints. So we're going to be fixing not just two discs, but we're also going to be fixing his sacroiliac joints today. By the way, the laser's working very nicely. You guys have got the energy levels really good. Any other questions?
Yes, we have a few more questions. Next one coming from John on YouTube.
It's John, not Big John.
Not Big John.
All right, we miss Big John.
This is John, armed PI and security officer.
All right, very good. Nice to meet you, John. Welcome.
asking, how often do you see scar tissue develop on the sciatic nerve from herniations?
Oh, that's a great question, John. I love your question. Yeah, often. So John's question was, how often do you see? And he's right. How often do we see? Because this is endoscopic spine surgery, folks. Let's talk about the seeing part of his question for just a moment. We are seeing inside the disc. As a matter of fact, we're seeing inside the tear of the back of the disc right now. This stuff I'm zapping with a laser is torn annular fibers. Now, this blue stuff is the herniation. And you can see it's torn the annular fiber, and the herniations are stuck within the torn annular fibers. And they're creating scar tissue. That's what this gold color stuff is, calcification within the scar tissue from the inflammation that occurs as a result of the herniation. So the first step is trauma to the disc that causes an annular tear, and it crushes the nuclear material, the nucleus pulposus, or jelly as you guys know. It crushes it into fragments, multiple fragments next to the tear. Then you guys go out and do your normal stuff, gardening, whatever, and you're pushing those pieces of herniation or fragments, you're pushing them out into the tear, out of the disc, and that's called a herniation. That's when it becomes a herniation. Those fragments of nucleus pulposus that are inside the annular tear are not herniations. They are waiting to be herniations. They're like passengers waiting to get on a plane, right? And if you think about it, your passengers are all sitting at the terminal waiting to get on the plane, but you cannot say that the passengers are either in the terminal or on the plane. You can say that they're in the terminal, they're in the walkway, and they're in the plane. So when the passengers are in the terminal, that is normal nucleus. When the passengers are in the walkway, that is like a herniation but stuck within the annular tear. And when the passengers are all the way through the walkway on the other side, which is in the plane, then they are like the herniation outside the disc. And that's what he's asking me. Do you see scar tissue when you look at the herniation outside the disc touching the sciatic nerve? The answer is yes. Almost always there's scar tissue there. All right, now before we take any more questions, let's show the audience how this whole laser thing works to fix herniated disc, to cure back pain, to cure leg symptoms such as weakness, numbness, tingling, and pain in the leg called sciatic pain.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see from our video, we use a endoscope to find the tear inside the disc, and we use a laser to remove the pieces of herniation within the posterior tear and the scar tissue and the inflammation and the herniations. So we're removing herniation, inflammation, scar tissue, calcification. Now, within that inflammatory tissue that we're removing with the laser right now, you can find tiny little nerve fibers that are pain fibers. And that's what gets activated, those little pain nerve fibers found within the posterior annular tear, next to the inflammatory, within the inflammatory tissue, next to the nuclear herniation. That's what we're getting rid of. That's why we get rid of the pain, because we're zapping away those little pieces of nerve fiber. which is why microdiscectomy does not work to cure back pain, which is why laminectomy does not work to cure back pain, which is why any surgery on the disc does not work to cure back pain, but this one, because the laser is killing the pain nerves while we're cleaning up the scar tissue right here. That is scar tissue right there. And what causes the scar tissue to form is the herniation. The herniation not outside by the nerve root, but the herniation inside the annular tear. Again, all this was elucidated by me. I'm the pioneer and the founder of this technology. I discovered that it was not the herniation that everybody sees outside of the disc pushing on the nerve root. That's not what causes back pain. It's actually the herniation stuck within the annular tear that's causing all the back pain. And that's what the Duke laser disc repair is, the only surgery in the world that focuses on the tear and not the herniation outside the tear. We do both, but we always clean up the tear, whereas other doctors never clean up the tear. And that's why we can cure back pain and they cannot. It's very simple. I've been trying to teach them for 20 years what we do, but nobody wants to listen. They all just want to keep doing fusions and pain pills and therapy and chiropractor, when the answer is right here in front of them, and I've been trying to show them. But I've given up on doctors, and I'm now focused on patients and just teaching the public exactly what needs to be done and how. To give you an idea of what we're seeing here, these are all pieces of herniation and scar tissue. That laser fiber right there is 1 millimeter wide, 1 mm, 1 millimeter wide. That's very small. It looks big in this endoscope because that's what the endoscope does. It makes small things look big. So part of the endoscope is not just looking inside your disc, but it's magnification and it's illumination, giving light and giving a bigger size so it can see things and I can operate precisely. All right, we're just about done. I got 30 seconds left on this disc, which is the L4-5, and we've just about completely cleaned up this tear. We're going to move on to the next disc, which is going to be L3-4 on the right, and the last disc will be the L3-4 on the left. Additional questions, Henry?
Yes, this next question is coming from Jason, once more on YouTube.
Yes.
Asking, is there any way a patient can tell pain is coming from facet joints?
Yes, Jason, absolutely. Facet joint pain is typically paramedian, meaning it's off midline, by about 2 finger breaths in the lower back, 1 finger breath in the neck, 2 finger breaths in the lower back, off midline. So if you take a marking pin and you mark dead center to your spine, where your spinous processes are, then you go off in the neck 1 finger breath, or in the back 2 finger breaths, and then you push with your fingers. If it's tender, that's facets. Other than that, just do the free Zoom call with me and I'll tell you what it is. We don't even charge for the Zoom call. It's free. All right, we're done. It's been cleaned up. By the way, the inside of this tube, the outside is 7 millimeter, inside 5.5 millimeter, about 5 millimeters. So that tear right there is around 4 millimeters. Now, how long will it take his body to heal that tear? It's going to take him about 9 months to completely heal the tear. Does it happen? Absolutely. And how do you heal the tear? You heal it by making collagen and elastin. Well, guess what? That tear is a tear in collagen and elastin. That is an annular tear, and the annulus is made up of collagen and elastin. So your body is going to heal that tear with exactly the same materials that it built it with. So it's a natural healing process. This whole surgery is a natural healing process. We don't put any metal, we don't put any plastic, we don't put cadaver bone. It is a natural repair. It is the very best a human being can get. We have people coming from all over the world for this surgery. Last week we had, well, not last week, the week before we had Israeli. We had, he was a welder. The Israeli was a welder. We had somebody else from another country too. Everything okay? Oh, I forgot. Where were they from? Huh? You guys are useless. Just kidding. God, another viral video. All right, go ahead. Pressure. Okay, let's keep the questions going. So we fixed one of the discs from the right side. That's the L4-5. We're about to do L3-4. Remember, L3-4 is bilateral, so there's a good chance we may get in there and actually see the needle from the other side inside the disc. So don't freak out if you see a piece of metal in there. Any other questions?
We have a couple comments and a question. This long and awesome comment is coming from Poodle Dog on YouTube.
Ooh, I like it. Poodle dog?
Poodle Dog, yeah.
Nice. I like poodles.
Comment saying, thank you, Dr. Duke, for showing and explaining what you do in surgery. It's so important and enlightening to us all who love you and follow you.
Aw.
You are a hero in medicine. The medical industry needs to recognize your skills in helping us many in suffering, and some cannot afford the money to have this done. We work all our lives for, and
Yes.
have Medicare and a second supplement.
Yes.
But they don't pay for this, and they should.
Thank you very much for your kind words. They are greatly appreciated, and I really, really, really love to hear that. So here's the good news. We are fighting the insurance companies with your help, the help of the patients. And I'll be honest with you, I don't care about getting recognition in the medical community because that's not important to me. I didn't go to medicine for my colleagues like everybody else did. I went into medicine to help patients be healthy and live good lives and be happy and not in pain, not suffering. And so my reward and all I care about is my patients being happy and being out of pain. That's all I care about. And so to be able to achieve that is the greatest thing in the world. And I thank God every day that these doors are open and we can come to work and we can take care of another person and improve their life, because that's why I went into medicine. As far as Medicare goes, someday we're going to get Medicare, I promise you. And it's going to happen when Trump or somebody from his administration or maybe the next president, when they actually have back pain and they find out about us, and they're going to come here and I'm going to tell them, we'll fix you, but you got to make this procedure available to the world, to everybody. And I'm going to make them force Medicare and the insurance companies to pay. And I'm just waiting for that day, trust me. I'm waiting very patiently. But I don't know how else we're going to get it done, because these insurance companies are so greedy. They don't want people having access to treatments that work, because then everybody's going to want it and they're going to have to pay for it, and they don't want to pay for it. That's really what it comes down to. They don't want to pay for it. All right, you guys see the needle from the other side?
Yes, we do.
Right there, I'm pushing on it. Okay, you guys see that?
Yes, we do.
And Luis is moving it. It's like a metal worm, all right? Now, if I hit that needle with this laser right now, it will melt the steel, and it'll melt the inside of the needle to the outside. So I got to be careful not to do that. The good news is, remember, this is a very precise laser. It is incredibly safe and incredibly precise. So I'm just going to work around the needle and not actually hit it, okay? You guys can grade me on my surgical skills. One thing I can do is I can turn my tube a little bit to the right and clean out some of that herniation there. And then I'm going to turn it to the left. I'm going to go on the other side of that needle. But so far, great audience participation. I know we have some more comments. Go ahead, Henry.
Yes, this next one from Jason on YouTube once more. And I love this, saying, we need a Dr. Duke world tour so more people can be blessed with your knowledge and talent. The fact that this isn't worldwide yet is unbelievable. You are like Gordon Ramsay of the medical world.
Oh my God.
I love this. You don't suffer donkeys or idiot sandwiches.
Yes.
That's why you set high standards for your staff.
That's right. I do. I care about my patients. I mean, I care about my staff too, but only in as much that they're helping me care for the patients. I know it sounds cruel and mean. I'm not a woke person. I really am here for the patients. I mean, let's face it. These people are suffering. My staff are not suffering. My staff are pretty much happy people, and they're paid very well. So we're not here for them. We're not here for me. We're here for my patient. And when my patient is in this operating room and they are under my care and our care, you better believe I'm going to be their guardian. I'm going to be watching everything happening in the operating room. If you guys think all I do is sit here and look down the scope and play with a laser, I don't. I'm paying attention to every sound in this room. I'm paying attention to what everybody's doing. Are they doing it right? because everything that's happening in this room can affect the patient. For example, if somebody does something over there in the corner with some rubbing alcohol and a cell phone, they may cause a fire to start. That's going to put my patient's life at risk. So I've got to be on the alert constantly, looking for things that are happening that shouldn't be happening. And that's how you protect your patient. And not only me, but everybody in this room is that way. Okay, I've selected staff over the years that are phenomenal. Yes, we had to get rid of somebody recently who was not phenomenal. But again, we tried helping that person for a long time because, well, to be honest, she's a single mother with kids, and we didn't want to just kick her out, even though she probably should have been kicked out a long time ago for her behavior. We kept her and we tried to fix her. But, you know, my wife always says to me, a leopard never changes their spots. So shame on me for not recognizing that and doing something sooner. But the rest of our staff are phenomenal. I have no issues with anybody here. They're all dedicated. They're like a great team. We're all focused on one thing, taking good care of this patient, making sure that while they're asleep, having a metal pipe stuck in their back, that they're going to have us guarding them, protecting them, watching them, monitoring everything happening to make sure they're safe. And that's what Duke Spine's all about. You go to other hospitals and it's a joke. The staff there don't care about the patients. Surgeons don't care about the patients. The surgeons will hurt the patient, not intentionally, but just out of, you know, I guess carelessness. And the patients suffer injuries during surgery. They're called complications. And when that happens, the surgeon just says, you know, we had a complication. I'm sorry you can't see out of your left eye anymore, but that's one of the risks of surgery. And you knew that risk when you came here. And I'm sorry that you're blind in your left eye for the rest of your life. Okay? That's not okay with me. I don't accept that. I reject that. I believe that we can prevent those types of injuries if we pay attention and we control our environment that's in the operating room. So I'm a big believer in control and making sure that everything in here is optimized for patient safety and patient outcome. And my team feels the same way. I speak for them all. They do most of this work and they make me look good, all right? I just walk in here and do my little thing with the surgery, but they set everything up. They make sure everything's sterilized properly. I mean, we haven't had a single infection in this surgery in 20 years. That's unheard of. It's unheard of to have spine surgery with 0 complications. But that is what we have. And it's driving my competition crazy. They are literally going crazy saying it's not possible for you not to have complications, surgical complication. But it is the God's honest truth. And the reason is my people, my good people.
Can we have a shout out to Remy for helping keep our patients safe?
Yeah, we're going to do a shout out to Remy out there, who is one of our most important coordinators and works closely with our anesthesiologist, Dr. Berndes, and the rest of our team to make sure patients that come here are ready for surgery. As a matter of fact, I'm going to tell you guys, we had a patient we canceled last week, okay? God knows we need the money to run this place, okay, because we're a small operation, and we canceled the surgery because it wasn't safe for the patient. So we lost that money. I made the decision with Dr. Berndes. We did not want the patient to have a bad outcome. So the patient was somebody who is in congestive heart failure, and they have been for a long time, and they had some extra fluid in their body, and we just knew that it wasn't safe to proceed with the surgery. So we basically canceled the surgery knowing that it would affect our revenue, but we did it because it was the right thing to do for the patient, not for us, for the patient. And the problem is medicine doesn't have a lot of doctors like that anymore. But Duke Spine, as long as I control this place, will always be that way. It's always going to put patient safety first.
Patients always mention they get a lot more attention and care here.
Yeah.
Other facilities.
Yeah, this patient, he's from Alabama. He was in pre-op, and we had 10 people around him, from the anesthesia to the nursing staff to the surgeon to the technicians to Luis, who's really like 3 people. And I mean, all that personal attention for one patient to make sure that they have the best possible outcome with their surgery. That's what we're all about. Thank you for recognizing that, people. I appreciate it. All right, we're almost done with this disc, number 2. You guys can see I never zapped that needle down there from the other side. But the reason we're doing, the reason there's another needle is because we're doing both sides at this disc. This guy has herniations on both sides, left and right, and he has symptoms in both legs. Therefore, I have to treat both sides.
He was thinking about scheduling for a fusion, a lumbar fusion, and
Oh, he was, yeah. So Dr. Berndez, I'll just say this. This patient was recommended for a fusion in Alabama, and he was going to do the fusion until he started reading about it and realized, oh my God, fusions are really bad, and so many patients have problems with fusion, that he found the Duke Spine Institute alternative to fusion, this surgery right here, and basically here he is. Here he is. By the way, you see this white stuff right
Yes,
here?
we do.
This hard white stuff. It's hard to see, but right there, that little, it looks like cauliflower or something, little white dots. That's calcium from chronic inflammation, and some of it is actually also from epidural steroid injection. They put this preservative in there that basically causes that calcium to form, that material to form. So it's bad for you. Epidurals are actually bad, but a lot of people have no clue about that because they never see the inside of a disc that's had an epidural done nearby. Okay? The doctors are not supposed to be putting medicine inside the disc, but somehow it gets inside the disc. So they really shouldn't be doing that. Anyway, any other questions?
Yes, we have a couple more questions. This next one coming from Warren on YouTube,
Warren, welcome.
asking, hey, Dr. Duke, how do I tell if I have facet pain?
Well, if you really want the honest answer, the way you tell if you have facet pain is you do a MRI review with me on Zoom. Wherever you live, it doesn't matter. I do it for free. It's a free service we offer to every human being alive. Doesn't matter what country you are. It doesn't matter if you can pay for a treatment or not. We don't care. We just want to help you. So get a free MRI review and telemed visit with me. But if you don't want to do that, the way you tell if you have facet pain is always to the side of the spine, either left, right, or both. If it's in your neck, you'll have pain 1 finger breadth to the side of the midline, and it'll be tender when you push on it. Tender and painful. And in your neck, especially the neck, if you turn your head to the side, it won't come out. It's a piece of herniation that won't come out. If you turn your head to the side, left or right, it'll make the pain worse. That is a clear finding of facet pain in the neck. For the lower back, you can't really turn your back left and right. It doesn't work. But if you extend your back up, like arching your back up, your chest up, that can sometimes exacerbate facet pain. The only way to know for sure is to have me check you out. There's another way you can do a facet block, have your doctor inject your facet, but I don't trust those doctors to do it right. So many of them do it wrong, and as a result, you get bad information. Okay, we're done here. We're going to move on to our last disc on the other side at L3-4. But you can see we removed all the herniation, and there's a little bit of fat in the epidural space. There should be a nerve root over there, but it's buried. And we've cleaned out the herniation. It's gone, and that will heal right there in a matter of 9 months to a year. Okay? Any other questions?
Yes, we have a question coming from Lanu on YouTube,
Hi, Lanu. Welcome to our stream again.
asking, why do some patients have uneven numbness? For example, left hand has more numbness than the right hand.
Well, it depends on what causes the numbness. So if the numbness is from carpal tunnel syndrome or ulnar neuropathy, then you may have it on one side or the other. That would explain. If the numbness comes from a pinched nerve, then a lot of people have one side pinched, the other side not pinched. Or if it comes from irritation of the nerve root, A lot of people have irritation on one side but not the other. If it comes from the spinal cord being pressed on, a lot of times that's asymmetric. Thank you, Luis. So there you go. Those are the reasons why. Because the type of diseases that cause numbness are not symmetrical. All right, 7mm incision. We're going to go to the left side and fix his L3-4 on the left. And then we're going to be done with the Duke laser disc repair. We'll move on to the sacroiliac joint Duke plasma rhizotomy. Let's keep going on the questions.
This next question is coming from Stuart on YouTube,
Welcome.
asking, Doctor, I have a question. What does this procedure cost? Not exact amount, but approximately. I am from Naples, Florida.
Great question. Well, it just depends on what your insurance will cover. So the cost to the patient depends on what their insurance will cover. Some insurances cover it, most do not. But the charge for this surgery is, I don't have the exact number, but it's tens of thousands of dollars. And it depends on how many discs you're having treated. So this patient has 3, right? He has 2 discs, but one of them is on both sides, so that's really 3. So that's going to be more expensive than somebody having 1 disc fixed or 2 discs fixed. Shot? So it really depends on how many discs are being fixed, how many sides are being fixed, whether the herniation or the laser surgery is being done on the lower back, the thoracic, or the neck. So each of those are different prices, because if you're doing this on the neck, you have to have general anesthesia. What's general anesthesia? That's the tube down the throat. This patient doesn't have the tube down the throat. He has local. All right, he has twilight. And twilight's cheaper than general. So there's a lot of factors that factor in to the cost. It just depends on many different factors. So I can't really give you a cost. A lot of people ask me that, and unfortunately I just don't know. I have no idea what he paid. I can tell you that in general the surgeon gets 5% of whatever it is, and the anesthesiologist gets 5%, and the rest goes to the surgery center. And the 5% I get doesn't go in my bank, it goes to pay my staff. So it really, almost all of it goes to overhead. All right, great question though. I appreciate you guys asking.
And at this moment, no current questions.
All right, remember we did this same disc on the other side. So we are going to see some blood inside the disc from the other side. That's normal to expect. This is the L3-4. Okay, and we are now inside. Like I said, it's a little cloudy because we're seeing blood from the other side that we did, passing actually through the disc, coming out to this side now. We're going to see if we can grab any pieces of herniation out. You can see how ineffective the grabber really is. People say, why don't you just use standard surgical instrument? Because standard surgical instrument doesn't work. So unless you're using a laser, you're not going to have anywhere near the result you need for the patient to get better. Wait. Some of these pieces of herniation are so big they won't even come out on their own. All right, questions?
Yes, we just got a question from Lanu once more on YouTube.
Before I take that, Berndes, I got about 8 minutes and we're done. But then we're going to move on to the SI joint. All right? Guys got about 8 minutes to ask questions, then we're going to move on to the SI joint.
Lanu once more on YouTube asking, do you have patients that flew to Florida and have MRIs taking at your facility and a meeting with you and surgery all done within a week?
Oh yeah. Yes, Lanu. As a matter of fact, I've had patients fly here, show up in the morning, get an MRI, see me, get a surgery recommendation, have surgery the next day, and then go home. So really just 3 days. We do it all. We do labs. We do EKG. We can do the clearance, the medical clearance for the patient.
As long as there's not extensive medical
Yeah.
concerns.
As long as the patient doesn't have a serious heart problem, like untreated heart disease, where they're going to need stents put in, you know, as long as they're stable, cardiovascular, pulmonary, liver, hepatorenal, everything is stable. You know, they don't have any acute failure of those organs. They can literally come here. Heck, we could do everything on the same day. I mean, we could literally do their MRI, their office visit with the surgery recommendation, and their surgery all on a Wednesday, and then they can go home the next day, Thursday, or the same day if they really want to. You can get their staple taken out at home. We can make this a one-day trip. That's what we're able to do. We love that because it's efficient. We like efficiency. You see, insurance companies want to drag out the patient experience as long as they can and do as many visits as they can make the patient have to come back, because insurance company knows that some patients are just not going to come back. They're going to give up. They're going to say, oh, I don't want to drive that far again. It's not really worth it. And so insurance companies have a policy that they're only going to pay for one thing every day. So if you were to come here with an insurance company and do the office visit, which is like $100, let's say, and then the MRI is $300, and then the surgery is $10,000, the insurance company would pay for the office visit, and they would deny the surgery, they would deny the MRI, and they would only pay $100 for the office visit. That's how they work. And they would say, if you fought them, they would say, oh, we only pay for one thing a day. And then you'd say, well, why don't you pay for the surgery? It's the most expensive. And they say, well, if you read our fine print, we get to choose which service we're going to pay for. And we're choosing the office visit. That's the kind of people the insurance companies are. They're absolute filth. They are worse than filth. God, filth is a compliment. There is no word to describe them. There was a movie made a long time ago that if you've never seen it, you have to. It's called Star Wars, the original Star Wars. And if you see the evil empire, that is what the insurance companies are. They are the evil empire. And we are the rebellion, trying to help people stay healthy and safe. Right, Henry?
Of course.
I think George Lucas got it right.
Oh, most definitely he did. I love Star Wars.
Anybody know why the evil empire has British accents?
Is it a metaphor from our conflict with the British back in the day?
That's what everybody thinks, but that's not it.
Why?
The real reason is all the banks and financial institutions, the ones that are insurance companies, for example, they are all based out of London. Lloyd's of London, for example, very powerful.
I did not know that.
AIG. Oh, yeah.
To incorporate the accent like that into the movie, that makes sense. Yeah.
Everybody thinks it has to do with the American Revolution, but it's not. It's actually the financial institutions that control our lives and make them worse. We are done here. Done. I think we're done. Let me just take one more peek. Let me just zap a little bit more there, just in case. There's some fat there. You can see the fat around the nerve. Fat is good. We like fat around our nerves. It provides energy for the nerve, so you can run and run and run, and your nerves have lots of energy.
We have a few more questions.
Okay, we'll take them because we're done, but we'll take those questions.
Coming from Jason,
Light.
once more on YouTube, asking, how many surgeries do you do in a week? And do you have someone you are training to continue your work?
Well, Jason, the number of surgeries I do varies depending on how many people come here. We can do a lot more than we do now. we could do a lot more, but we just don't have the volume of surgeries that I would like to have. So someday I'm hoping that we can do 100 a week. But right now we're probably doing 3 to 4 a week, I would say, on average. Any other questions?
Yes, this next one coming from Lanu once more on YouTube, asking, do people pay the surgery in cash, not using insurance, just 100% cash?
We have some insurance. We have some cash, pressure. We, I don't know if cash, I think they pay with wire transfer and with Care Credit. I mean, they use credit cards, things like that. Care Credit, wire transfer, cashier's check. I think we even had one patient pay us with Bitcoin, right? One time, Bitcoin. So, but yeah, we're pretty flexible in what we take. Heads of our enemies. Chicken, goats, sometimes, right, Dr. Berndes?
And that is it for questions.
All right. Thanks for joining us. We're going to be back shortly with our next surgery, which is our sacroiliac joint treatment for with